Let's begin. Hello, everyone, and welcome. Good morning, good afternoon, good evening, depending on wherever you're joining us from. On behalf of ISP's webinar subcommittee, I'm Geeta Iyer, a senior research scientist at Harvard Pilgrim Healthcare Research Institute and a research associate at Harvard Medical School in Boston. I'll be moderating today's webinar on medication adherence matters from data to action. Before we get started, a few housekeeping notes. I just want to say that all of your lines are muted. So if you need tech support or just have general questions, unable to hear or anything like that, please use the chat box that's on the Zoom kind of feature on the Zoom panel below. If you want to submit a question to the panelists today, please submit that question at any time during the presentation in the Q&A feature on your Zoom panel as well. The questions will be answered towards the very end of the session, where we'll have some time for these questions in the order in which we receive them. We don't have enough time to go through all of the questions. We'll try and follow up on those responses. I do have it on good authority that the presentation today is going to unfold as a narrative, and some of the questions that you may have had initially in the kind of presentation will hopefully be answered as the kind of presentation and the slides move on. The final housekeeping note that I have is that the session is being recorded and will be made available on ISP's website in the coming days. So coming to the topic, anyone who's working in healthcare right now or healthcare research will be able to tell you that medication adherence remains one of the most important and challenging issues in healthcare today. We have a lot of data that we have access to, so unprecedented access. We have some understanding of how effective and safe medicines are, as well as a lot of new medications being approved each year. But translating all of this information into meaningful actions that actually support patient outcomes is an ever-evolving science, basically. So leading today's session are three experts in the field who spent quite some time thinking about doing just that, translating data to action. Dr. Stella Talik is the head of the Pharmacoepidemiology Research Group and senior assistant professor in clinical epidemiology at Monash University's School of Public Health and Preventive Medicine. Her work focuses on optimizing medication use, improving adherence and safety, and strengthening chronic disease prevention and management. Talik leads a multidisciplinary program spanning real-world evidence, clinical epidemiology, and pharmacoepidemiology. With her today is Dr. Harvey Koh, who is a postdoctoral research fellow and the lead of digital pharmacoepidemiology within the Pharmacoepi Research Group. His work focuses on developing novel Bayesian machine learning methods and trajectory mining methods for pharmacoepi. Ms. Caroline Trin is a PhD candidate in the Pharmacoepi Research Group at Monash University as well. She also serves as a teaching associate and a short course coordinator within the faculty. Her research focuses on addressing medication adherence in cardiovascular disease prevention through a mixed methods approach, integrating both quantitative and qualitative research. With this introduction, I'll hand the meeting over to Dr. Talik. You're right.
Thank you so much, Geeta, for a lovely introduction, and welcome everyone. It's great to see so many people online. So just before we start, we would like to say that we have no conflicts of interest to declare in relation to the content of this presentation today. And we are proud that this work on medication adherence here in Australia is supported by the Medical Research Future Fund. We have spent over 7 years looking into this problem, and hopefully some of the insights that we share today with everyone will be insightful and also helpful in understanding how we can potentially approach medication adherence into the future. So because Geeta provided such a lovely introductions, I'm going to skip these couple of slides. Just briefly, both myself, Harvey, and Caroline work in this space. We have different skill sets, and we have combined them together in trying to unpack such complex constructs such as medication adherence. I'm coming from more quantitative but also mixed methods backgrounds. Harvey's coming from big data, AI, machine learning, and digital health, and Caroline from that kind of consumer and stakeholder engagement, qualitative research, and qualitative evidence synthesis. So for today, we've got a couple of learning objectives. We will take you through some of the traditional adherence metrics, and we will try to explain why these potentially do not capture the complexity of patient behavior. We will take you through some novel methodologies and more advanced analytical methods that we can use to interpret the dynamic adherence trajectories, such as process mining, Bayesian hierarchical modeling, and trajectory modeling. And we'll talk about how we've applied that in cardiovascular prevention in primary care settings to unpack adherence. We'll talk about how we can translate patient-derived insights from qualitative interviews into practical actions and how these can serve to design targeted interventions for enhancing medication adherence. And also how all of this research, when combined together with these novel methodologies, can be used to apply more innovative but scalable prediction models to strengthen that assessment of adherence at the point of care, and also interventions that may be useful in bringing people back on track in how they use their medicines. So to start off, I think a lot of you are familiar with the definition, measurement, strengths, and limitations, but just as a bit of a refresher. So medication adherence, as we all know, refers to the degree to which a patient follows basically their healthcare provider's instructions regarding the timing, dosage, and frequency of their medication. But we know that it is a major challenge in healthcare. According to numerous data sources, including the World Health Organization, approximately 30 to 50% of all medications that are prescribed for chronic diseases, and that mainly involves cardiovascular, respiratory, diabetes, and mental health, are not being taken as recommended. So it's a striking number and represents this challenge that we see that medication adherence is really a burdensome risk factor, but somehow neglected in the whole scheme of things. It is very common, and we also know that non-adherence significantly can increase hospitalizations, leads to poor disease control and progression, and increase various different complications for patients and mortality rates. One of the major, I suppose, challenges with medication adherence is that, as you probably know, there is no single method that fully captures it. So we are now very confident that it's not a simple and binary concept. We can't really classify patients as just adherent or not adherent. We do therefore approach adherence as a dynamic construct and time-varying construct, meaning that patients' medication taking behaviors truly change over time in response to different factors, different barriers and challenges that they have. So for example, what we can see from the slide is this kind of full pathway of patients' medication journey. We know that from the literature, only a small proportion of patients, that's often less than 20%, remains consistently adherent over time. But then we've got some patients who will discontinue very early on. We've got patients who will stop and later reinitiate their therapy. And then some patients who never start treatment and permanently discontinue. And because these behaviors shift throughout the treatment period, capturing and accurately measuring this adherence over time becomes very, very complex and challenging. You've all probably have heard and know really well medication possession ratio and proportion of days covered. These are the traditional methods that are commonly used to assess medication adherence, and that's based on the pharmacy refill and dispensing data. Medication possession ratio, or MPR, basically estimates adherence at looking at the amount of medication a patient has received over a specific period. And we know that it's a relatively simple measure to calculate, and it's widely used in research, as I said, using that administrative pharmacy claims data. But a key limitation is that it can sometimes overestimate adherence, particularly when patients refill medications early and there is an overlap between prescriptions. On the other hand, we've got proportions of days covered, or PDC. It's a very similar type of measure, but it's considered more conservative and more widely used. It basically estimates the proportion of days within a given time period that a patient has medication available, while accounting for those overlapping prescriptions that I mentioned for the MPR. And because of this, PDC cannot exceed 100%, and it's often a preferred method for monitoring adherence when we talk about using pharmacy claims data, and also from a healthcare quality assessments point of view. Now, these measures are very useful. We're definitely not saying that they're not. They both rely on dispensing data, and they're widely used because they're objective, they're scalable, and they can be easily applied to large administrative data sets. It makes them particularly useful for population level studies that we often see in the literature, range of health services research, and others. They are relatively easy to calculate and reproducible, but there are important limitations that we need to think about when we use these measures. They only capture that medication dispensing, and they do not provide the reasons into the medication's non-adherence. We know that medications non-adherence may be intentional, unintentional. People can change doses. There may be side effects because of which they're stopping their medications, or they may be influenced just purely by patients' beliefs. So this example very well clarifies and illustrates one of the key limitations of both of these measures. We see here we've got patient A and patient B, and both are classified as adherent because they have basically the same MPR and slightly different PDC, but still would be classified as adherent. When we look more closely at their medication taking behavior, these patterns are actually quite different. Patient A has a continuous 15-day gap without medications, where patient B has several short sporadic gaps across the observation period. And despite these differences, both patients appear equally adherent when measured using MPR or PDC. So this basically highlights what I've spoken about in terms of the limitations. They do capture overall medication availability, but really fail to capture these unique patterns and clinically meaningful differences in behaviors over time. As a result, patients with very different medication taking behaviors will be classified in the same way, and that masks this important adherence issue that I will talk in a moment. Now, moving on to other methods that we commonly use for measuring adherence, we all have heard about patient-reported outcomes. They're very useful and certainly should not be dismissed. They serve a different purpose compared with pharmacy-based measures. Basically, what we know is that these tools are designed to capture patients' perspective and self-reported medication taking behaviors, which can provide valuable insight into why the non-adherence occurs. One commonly used tool, as an example here, it's Medication Adherence Report Scale, or MAS5. It's a 5-item self-report questionnaire used to assess medication adherence. And it basically asks patients about behaviors such as forgetting to take medications, altering the dose, missing doses, or stopping medications, whether permanently or temporarily. Patients indicate how often these behaviors occur, and higher scores indicate better adherence. Now, MAS5 is widely used, and we use it in our research group as well. It's short, easy for patients to complete, and able to capture both intentional and unintentional non-adherence behaviors, which are often difficult to identify using dispensing data alone. But looking at this figure here, we can see that there are some limitations. The patients report sometimes forgetting to take medications and sometimes altering the dose. However, when we look at the MAS5 scale, all domains are weighted equally. and the scoring works in a relatively, we could say, simple way. Because of this, we're not able to distinguish that relative importance or severity of different adherence behaviors. Another issue here is the ceiling effect. So in practice, a patient would need to report problems across multiple domains of this scale before their score will meaningfully reflect non-adherence. But we know in reality, and from our research as well, that many patients usually experience one main adherence barrier, and that can be forgetting medications or intentionally adjusting the dose. So as a result of this, the scale still may classify them as highly adherent. More broadly, self-reported adherence measures have also another several limitations that are worth noting. They may lack validity and precision compared with objective methods, such as pharmacy refill data. They also combine different behaviors into a single score. And also, these tools are not able to capture those behavioral patterns over time and identify the underlying reasons influencing their non-adherence. We also know from research that they tend to overestimate adherence, as patients may unintentionally misreport or provide socially desirable responses. Another challenge is that different adherence scales measure different aspects of medication taking behavior, and studies very often use different scoring systems or cutoff values, which makes comparisons between studies very difficult. Finally, it's also important to remember that self-reported measures capture patients' perceptions of their behavior rather than the actual medications intake. And that can further limit their accuracy. To better understand what's actually happening with self-reported, patient-reported outcomes, such as MAS-5 responses, we've tried to unpack the scale rather than treating it as a single total score measure. To do this, we've applied a statistical method called latent class analysis, which helps identify hidden patterns or groups or clusters within the data based on how patients respond to different questions. And what we found was actually quite interesting. Intentional non-adherence behaviors, such as stopping medication or deliberately changing the dose, were much more strongly associated with overall non-adherence. So these behaviors much better differentiated between patients with different levels of adherence. And on the other hand, what we also found is that unintentional behaviors, such as simply forgetting to take medications, had a much weaker relationship with the overall non-adherence construct. So what that means in simpler terms is that not all adherence behaviors contribute equally to the overall outcome. Intentional actions where patients actively decide to change or stop their medications appear to be much more important in defining the true non-adherence, whereas that occasional forgetting may reflect a very different and often less severe type of adherence problem. So what this highlights and tells us is that looking beyond a single summary score and examining the underlying behaviors can really provide a much more meaningful understanding of adherence. So to wrap it up with current measures and traditional adherence measurement approaches, there are various strengths on why we use them, but also we need to be aware of the limitations. They're very useful indicators in research and clinical practice. From pharmacy refill and quantitative data using traditional measures, we can analyze large populations. They do serve into understanding, the burden of adherence on a population level, which is very useful as a starting point in unpacking adherence. They are objective. Self-reported tools capture reasons for non-adherence to a certain degree, as we've just explained, and they're easy to administer in most cases at a low cost and scalable. But there are limitations that I've just mentioned that we need to be aware. And within those limitations, we really need to be mindful and careful in how we decide which measure and for what purpose we're going to use. But I also want to add that adherence is not just a behavioral problem. It is a behavioral construct, but it's also a fundamental issue of exposure measurement in pharmacoepidemiology. It is often studied within the behavioral kind of science because it reflects that patients' medication taking behavior, as I mentioned. And in many studies, it's treated as an outcome where we try to understand what factors influence whether patients will take their medications as prescribed. But also we need to understand and know that adherence is commonly treated as an exposure variable. And that's happening in this pharmacoepidemiological study that are examining, whether higher adherence level leads to better health outcomes. It's also very applicable and important for clinical trials. When adherence is used as an exposure, there are several methodological challenges and biases that we need to be aware of. One well-known is the healthy adherer bias, where patients basically who adhere better to their medications are more likely to engage in other healthy-related behaviors. Another issue is time-related biases, such as immortal time bias, where patients must survive long enough to be classified as adherent. And that can potentially, and very often we've seen, artificially inflate the apparent benefits of adherence. And there is also this problem of misclassification, because when we use those traditional pharmacy refill data, we assume that medication is obtained, the medication that's dispensed is actually taken, which may not always be the case. So basically what this highlights is that adherence is not simply that kind of just one-way behavioral measure, but a complex pharmacoepidemiological construct. And it highlights an important point in medication adherence research. So before we decide on choosing an analytical method that we want to use in our research, we need to clarify the scientific question we are trying to answer. And there are basically three main types of questions that researchers often ask. First, we may want to predict who will stop the treatment. And this is a risk prediction question. The goal here is to identify patients at higher risk of discontinuing therapy. So in this case, analytical approaches such as risk prediction models or survival analysis will be best to estimate the probability of or timing of treatment discontinuation. Secondly, we may want to understand patterns of behaviors over time, and this is what Harvey is going to talk about in a moment. The goal here is not just prediction, it's describing how adherence changes during treatment. And there are various methods such as trajectory analysis or clustering techniques that are useful for identifying those groups of patients with similar medication taking patterns. Thirdly, we want to estimate what would happen if patient is adhered to treatment. And this is a causal question. Aims to understand the effect of adherence on outcomes. And obviously for this, we need a range of causal inference methods to estimate the outcomes under hypothetical scenarios that we may have on how patients are following the prescribed treatment. So the key takeaway from here is that these are fundamentally different scientific questions, and therefore each requires very different analytical strategies. So choosing the correct methods really depends on that clearly defined research question and research objective, and obviously on the data that we have. Choosing the right methodological approach is a key. We always need to remember that. Adherence is a time-varying and prognostic construct. So those standard regression adjustments that we use in epidemiology would not be sufficient. I will now pass it on to Harvey, who's going to talk more about understanding the dynamic medication adherence through advanced analytical methodology, and he will provide an example from cardiovascular medication adherence in primary health settings. Harvey, over to you.
Thank you, Stella. I would like to start this presentation with a small example. Here are 3 patients. Do these patients look the same to you? Because according to proportional days covered, or PDC, they look exactly the same. This is what Stella was talking about. A static measure does not give you a good idea on patients' behavior, not because there aren't good measures, but because they don't look at the third dimension, time. So the idea is pretty straightforward. Take the concept of adherence behaviors through time and allow for emergent behaviors of medication adherence to be classified based on dynamic adherence. We can then add our interpretation of these pathways or trajectories after, allowing us to have insights into these adherence patterns. I'll introduce you to 3 separate algorithms and concepts. The first is group-based trajectory modeling, followed by heuristic mining, and first-order Markov model, or FORM. The first one I'd like to go through is group-based trajectory analysis. This is what currently the gold standard is for measuring adherence by the community at large or in the pharmacoepi space. Group-based trajectory analysis is a statistical method that takes longitudinal dispensing or prescription data and identifies distinct subgroups of patients over time. Group-based trajectory analysis fits latent class growth curves to monthly PDC values, and the algorithm tests a range of possible group numbers and selects the optimal number, assigns each patient to the group where their posterior probability of membership is the highest. So in this particular case, we would discover that we have four separate archetypes: persistent adherence, gradual decline, rapid decline, and early discontinuation. All of these can then be explained. All of these can then be explained after you group them up. The first one I'd like to explain to you is gradual decline. Gradual decline is characterized by a group who has a higher polypharmacy burden, and they're relatively slowly disengaging from therapy. The second group I would like to describe to you is rapid discontinuation. These groups are described by a slightly higher prescription disruption rate, and they're also, relatively speaking, younger compared to persistent adherence, have a lower comorbidity, so they're asymptomatic, and they have a higher uncontrolled lipid lowering LDL, since they don't take the lipid lowering medication at all. The third group I have for you in this particular case is rapid decline. The group that switches really early, but finds that probably they have interactions with other drugs, or they're intolerant to statins. Again, relatively low comorbidity burden and relatively younger age as well. We can then fit these into, again, GBTA. One of the main limitations of GBTA is that it assigns all of these groups post hoc. It assigns and you cannot update them in real time. To fix that, one of the things we can do is to build a Bayesian hierarchical model on top of the GBTA clusters to predict which group of these patients belong to prospectively. The second method I have for you is heuristic mining in process mining. Now, heuristic mining is a process mining algorithm that reframes medication adherence not as a curve or number, but as a clinical workflow. Each patient's dispensing history, as you can see here, is converted into a process trace and a chronologic sequence of discrete events, such as when you initiate, when do you refill, on time, whether you're late, whether your gap on reinitiation or drug filling exceeds those 30 days, and discontinuing. In this case, the map that our data produces in this example shows a really, really clear story. You have most patients who refill on time and becomes a habit, and then these patients eventually just stay adherent throughout. The second one would be the discontinuation pathway. These patients are late to their refill. They have a gap and eventually discontinue from the drug. The final method I have for you is first-order Markov model. It takes a fundamentally different approach from group-based trajectory analysis and heuristic mining by looking forward rather than backward. It takes the patient's PDC into four states: adherent when it's 80 and above, partial between 0 to 79, and non-adherent below 40. And it estimates these sort of matrices that allows you to from one patient to go from one state to another. For example, one person could be from adherence to statin, switch from adherent from statin to switching to another drug. They could add on another drug, and they move from one state to another, and they move through the transition matrix. The idea is that by using this, you can understand when the patient is in a state, we can predict the next step where they would go, creating a nice probability chain. I would like to compare all these methods together now. And each method of these sort of answers a different clinical question. The first one, GBTA, tells you who. It phenotypes patient into trajectory groups. And you learn that maybe 40% of your cohort are early discontinuers and 29% are rapid decliners. Heuristic mining tells you the how and what path the patient takes through the system. You learn that the late to gap transition is the critical bottleneck where the patient falls off the adherent path, maybe. And finally, the first order Markov model tells you what is next. It predicts the immediate next transition available for each individual patient. For example, you learn that if a patient currently in an adherent state has a 24% chance of deteriorating into the next state. Together, they form a complete picture. Identify the at-risk patient phenotypes using GBTA, understand the process failure point with heuristic mining, and trigger the real-time intervention with first-order Markov model. Again, I would like to say that while latent class analysis gives us more insights into the who, the how, and what happens next, it still doesn't really fully explain the complex psychosocial behavior of patients or the why. For that, you'll need a missing piece, the qualitative part of the equation. I'll pass it on to Caroline for that.
Thank you so much, Harvey, for that amazing transition there. So now I'll be focusing on, again, the qualitative component. So as Harvey mentioned, we really addressed what and when through quantitative research. Now we're looking on to really understanding why these behaviors occur. So as you know, medication adherence is very much a complex behavior that is dynamic in nature and changes over a period of time. It is influenced by external as well as internal factors that really drive these behavioral mechanisms. Now, to really unpack this further and really explore this phenomena of interest, we really use the conceptual framework guided by the World Health Organization, and this really captures the 5 domains that really drive these behaviors, and they are condition-related factors. We look at patient, therapy, social and economic, and lastly, those healthcare system-related factors that influence these behaviors. So this is an example of a study that I conducted, which was a qualitative evidence synthesis. And this was on a global scale on the cardiovascular population group. I just wanted to also highlight that this particular methodology, as well as these findings, are very much relevant across different chronic conditions, not only cardiovascular space. And here we employed the per person maximum variation sampling method, which was an approach used to sample papers that represent different perspectives across population groups. And they were low-income papers. We really addressed primary CVD prevention groups, secondary CVD prevention groups, rural regions, and lastly, those underserved communities. Now, based on these findings and on this slide, it is quite heavy, and this really shows the extensive barriers and enablers that, again, influence medication adherence, which I won't go over too much. However, what I wanted to really get out of this was to highlight that different subpopulation groups have unique barriers that really drive different medication adherent behaviors. So let's explore some of these. In rural populations, we saw that access was a really big issue. So in terms of accessing healthcare services as well as medication, we looked at cultural and spiritual beliefs, and that really fueled negative perceptions regarding medication usage, and this really drove non-adherent behaviors. Moving on to low-income groups, we saw that financial hardships was definitely an issue, as well as mistrust in the healthcare system. And this was due to individuals not being able to afford that high-quality care. Now, very interestingly, according to primary versus secondary CVD prevention, what we really noticed was in the primary CVD prevention group, a very noticeable barrier was the lower perceived CVD risk. And this was often due to individuals being asymptomatic or borderline diagnosed with chronic conditions. And this was very different to secondary CVD prevention, where they had a higher perceived CVD awareness and risk. And this was often due to experiencing a CVD event or witnessing others going through something very similar. And lastly, we see underserved communities, and they experience lack of personalized care. And lastly, that poor patient and provider relationship that really drove non-adherent behaviors. Now transitioning on from a global scale, we now focus on the Australian context. So here I did a qualitative descriptive study, which really explore these domains in greater depth. So patient-related factors, we actually saw that inadequate knowledge and understanding led to increased fatalistic views about their medication. And this was further driven by experiencing side effects and drug-to-drug interactions that not only affected their mental well-being, but also social, emotional, and physical well-being. In terms of social and economic related factors, we did highlight the indirect and direct costs that were associated with medication, as well as a lack of resources that were readily available to them. So as a result, this created a lot of misinformation spread, and this was due to not having that adequate knowledge about how their medication is working or their condition. Moving on from that, in terms of those condition-related factors, we saw poor physical and mental health challenges. And lastly, on a structural level, we saw that poor patient and provider relationship was a barrier. And this was fueled by inadequate qualitative quality of care. And this was characterized by inadequate personalized treatment and poor multidisciplinary care. This was particularly more relevant for those experiencing more multi-morbid conditions. And as a result of that, required more specialized care from different departments and disciplinaries. So now I would like to just really reflect on the methodologies. We heard Harvey's segment where he really explored the quantitative studies, looking at group-based trajectory analysis and really identifying those distinct trajectories, which really highlight those different behaviors. And now moving from that, we look at the qualitative component, so really understanding different behaviors that drive non-adherent behaviors. And they were the costs, side effects, forgetfulness. But what we see is in terms of these two disciplinaries, they oftentimes do not work together in pharmacoepidemiological research. And what we see is a clear methodological gap. Now, to conceptually bridge the two together, we pose the question, what barriers influence different behaviors? And who better to ask than those who live through these experiences and challenges, as well as exhibit these different behaviors? So what we did was a co-designed mapping study with those with lived experience. And what we found through here was we got those individuals with lived experience to reflect on the extensive barriers identified through qualitative research. So that was through the descriptive qualitative study and those qualitative evidence synthesis that we discussed earlier. And what they were required to do was reflect on their own experiences, and they were required to map those barriers to distinct medication adherent behaviors. So following along, in the gradual decline, what we found were the lack of motivation, emotional strain, lack of support, living far from healthcare services. Moving on to rapid decline, we found a stronger preference for natural and herbal medicines, emotional strain, experiencing side effects and drug-to-drug interactions, poor multidisciplinary care, and lack of support. And lastly, in the early discontinuation, we found barriers associated with that preference again for natural and herbal medicines, side effects, drug-to-drug interactions, and poor multidisciplinary care. And why does this matter? So now we have identified those relevant barriers that really drive non-adherent behaviors. It allows us to really understand this phenomena of interest. From there, what we can do is design targeted strategies that address these specific barriers. And from there, build more further to really create and design more patient-centered interventions that are relevant, appropriate, and can improve health outcomes, which in turn will improve medication adherence. Now I'll be moving on and passing it over to Dr. Stella Talic, who will be moving on to really discuss how data can be transformed into action.
Thank you, Caroline. So I think we've heard a very good insights. Obviously, we presented a case study on cardiovascular disease and how we've approached adherence from using more novel quantitative methods, and then complementing that with the qualitative insights and bridging the gap between the two. There are models that exist that can combine the two disciplines together, but choosing the right methodological approach is basically the key answer. And we also can't forget that this also largely depends on the research question that we have. So going back to what I've mentioned at the beginning, and also type of the data we've got available and the level of complexity that we want to capture. So for example, what we would like to suggest is that if the goal is to identify different adherence trajectories, then those latent cluster trajectory models are probably the best way forward and most appropriate. And then if we want to model transition between different adherence states and really understand how that occurs, multi-state models seem to be probably the best way forward. When linking adherence patterns to clinical outcomes, joint modeling approaches can certainly be applied. But finally, I would like to highlight from what we've done, the Bayesian hierarchical models are really very valuable, is a very valuable modeling technique that allows us to integrate that prior knowledge, particularly in our case, barriers and enablers to medication adherence when they are mapped to those trajectories. We can account by using this model for range of uncertainties from a statistical point of view, and we can also model heterogeneity across patients and healthcare systems, which is very large, as Caroline presented in earlier slides. So again, choosing the right method depends on what we want to do. Sometimes combining multiple methods is a way forward, but particularly thinking about how we can combine that qualitative data with quantitative perspective is probably the key if we want to develop targeted interventions and really understand not only risk profile, the patients that are at risk of non-adherence or gradual decline or rapid discontinuation, but also understand at which point what problems they may have in those transitions to be able to develop those targeted interventions. So we've kind of suggest that integrating all of these requires more advanced statistical frameworks, probably multiple that combine behavioral science with pharmacoepidemiological modeling. And this is a bit of busy slide, but I'll take you through it. I think the main part of this is that we think that we need to really start moving from simply measuring adherence to actively using data to inform clinical action. We don't have that much time today to explore this in detail, but hopefully there will be other webinars in which we can take you through how this can be translated into clinical decision support tools and being used at the point of care. It's very important to understand that intervention development and digitalization of tools that can happen and can be derived from predictive models. And to move in this direction, we can leverage real-world clinical data that we have. And as Geeta was saying at the beginning, we've got a large amount of this data that it's not being used for these purposes. So we really need to start thinking how we can move from those more kind of, claims-based burdensome measures to more real-world clinical insights into what's actually happening at the patient journey level. There are enhanced approaches and methods, which I hope that we have explained to you today and that many of you will start using. It's very important to approach, I suppose, adherence from that kind of behavioral methodologies, and very important to use the models that allow us to obviously input qualitative barriers, which are very important because they do largely drive that kind of patient behavior. And one promising approach for this, as we demonstrated to you, involves that Bayesian hierarchical modeling that I've mentioned, because it allows us to incorporate that prior knowledge about the adherence domains, the barriers, and the patterns that have been observed, not only in our studies, but we can take that from other studies in the literature. These models can generate more robust, interpretable, and clinically meaningful estimates, and can be also used at a point of care. And if we're using clinical data rather than dispensation data, they can also be embedded straight into the EMI and clinical systems. The ultimate goal is to translate these insights, as I said, into clinically actionable tools. We want to be able to identify patterns early. We want to be able to have predictive models that we could trust, but they can also help flag patients who are at risk of declining or treatment discontinuation, so that clinicians can provide more timely interventions at the point of care. Another critical point that I want to mention to wrap up today is what Caroline mentioned: co-design with patients and people with lived experience. Their perspectives help ensure that the barriers we model and the interventions we develop are meaningful, are practical, and are patient-centered. So I guess in this way, we can really begin to close this loop between data, modeling, and clinical action, moving from simply describing adherence behavior, as we see in literature quite a lot, to predicting it in real time and ultimately, hopefully, improving patient outcomes. We still have a long way to go to get there, and hopefully in the next 5 years, we'll be able to say that by embedding these Bayesian hierarchical models and co-design studies that we have done will be implemented in clinical practice and the point of care, and that we'll be able to actually see some changes in patient outcomes into the future. So I think I'm going to stop here. We hope that today's session has been useful and informative for many of you. Our aim was not only to refresh some of the knowledge that you may already had around medication adherence, but also to provide new insights into emerging methodological approaches in this field. We also believe that kind of continued collaboration between researchers, sharing knowledge, clinicians, data scientists, and patients with lived experience will be really critical in advancing this field and ensuring that methods we've got and interventions that we develop are scientifically robust and meaningful in real-world settings. So thank you very much for your attention and engagement. And after studying medication adherence for years, I guess the real question is, did everyone adhere to the webinar schedule today and stayed until the end of this talk? We want to thank you for your adherence to the presentation, and we want to also acknowledge the entire Pharmacoepi research group, without whom this work would not have been possible. Our people with lived experience, we've got around 400 people with lived experience in our pharmacoepidemiological consumer network database who've contributed largely to this research and made it very meaningful. The Medical Research Future Fund for the funding, our primary health partners, IQVIA for providing the primary care data for making this research possible, MedAdvisor for recruiting many participants across Australia for informing this research, other chief investigators and partners on the project, and also ISPI for giving us opportunity to share this knowledge with you. And we're happy to take questions and comments from the audience.
Thank you so much. That was an excellent presentation. It really took us from all the way to the basics to the more complicated and more advanced methods, many of which I never even heard of. So I really enjoyed it. Thank you so much. So I'm just, please, if you have any specific questions that you'd like the panelists to answer, feel free to put it in the Q&A chat. There is one question which is on the chat, which talks a little bit about is the fact that is DBTA different from DBTM? I guess that's just group-based trajectory analysis, which is the language that you've used compared to, I think, group-based trajectory modeling. In continuation, kind of asking that usually in GBTM, logistic regression is conducted to understand factors associated with these trajectories. Does GBTA generate phenotypes differently without logistic regression? So I think there's just like a bit of a question about that.
Same construct, but Harvey can explain a little bit more.
Yeah, thanks for that question. GBTM and GBTA are effectively the same model. They're just two different names for it. That's the best way I can explain it. It's just different terminology.
I think to kind of go on the same question a little bit, if you don't mind. So I think one of the questions that I had about GBTM, because this is something that I kind of dabbled in a few years ago when it was still relatively new. And one of the things that I wanted to ask was, you said that it's more of a post hoc because you have the data collected, you're looking at the data, getting posterior probabilities of whether patients are adherent at that particular time and so on. My question is, when you're looking at those patterns, the kind of figures that you generated, were those kind of characteristics that you were able to kind of attribute to a particular type of phenotype? Were those all measured initially the study started, or were those things occurring over time as well? Because that's something that I feel like would be really interesting to see, is whether, over time, things changing are also taken into account there.
Sorry, Geetha, can you repeat that question?
Yeah, sure. So I guess my question was, so in the kind of almost, which looks very similar to, I don't know what the figure is called essentially, but it looks very similar to the pragmatic trial pre-C diagram. Apologies if I don't know exactly what that figure is called, but kind of getting at the idea that does, just like John kind of is talking about, usually you could kind of get a sense of like, okay, these patients who are always adherent versus kind of declining adherence and rapid decline, you're able to get some predictors of who these patients are. And I was wondering whether that can be done in a time varying fashion, incorporating the time varying data, or is it more so at the start of the study, where they're on polypharmacy and stuff like that?
There are studies that have been done polypharmacy using GBTA as well, to my knowledge. And they all use the same factor, which is you tend to vary the time. Because I think group-based trajectory method, as far as I know, is mostly the concern of variation of the trajectories over time. I hope that answers the question.
And I guess to answer that question, Geetha, the way we've modeled it, because we had the very, in this particular example, we had 10 years worth of data, and we were able to model it within the 6-month periods. So we had 6-month windows, and then that changes would be captured over time if you want that to be captured. So it can be done both ways at the beginning. If it's a research study and it's a retrospective cohort, for example, obviously you would probably model them at different time points, let's say at every 6-month window, because we know that mostly, within 6 to 9 months, patients' behavior kind of change. And that's what we are getting from the qualitative kind of insights and interviews and from consumers. If it's something that's going to be embedded in clinical practice, like we are doing now, we want to embed this model as a clinical decision support tool in primary healthcare practice, then it would also have to be, at certain time points. So every 3 months or every month or whenever the assessment is done based on the previously collected data. But it's definitely time varying, and you can do it within the model multiple times over the time that you're modeling. And those phenotypes can change. And I guess the main point of that slide was just to show that there are specific phenotypes, the risk profiles within each trajectory, but they're very much always based on the quantitative data, right? So you've got people with polypharmacy, people who switch a lot through their medications or titrate their therapy, people with multimorbidity, and people on polypharmacy. And it's important to understand, obviously, as you said, whether that changes over time, but it's equally important to understand at the beginning, if this is used at a point of care, so that you can get some of a red flag, this patient is likely to decline group. Yeah, and then you track how that changes over time.
Okay, thank you. There's a question about whether you can share the citation for the 2026 code trend and Tillett's paper that was mentioned in the presentation.
Yes, we will share the slides afterwards. Our model is currently under review and will be available as a preprint very soon in the next couple of days.
There's a question that I think, Harvey, you're answering live. I'll move to the next one, which is kind of talking about, in the data you use, are they specific to a condition or a chronic condition? How would you define when you are kind of using the data as adherence versus non-adherence itself?
Yeah, so we still rely on, there are multiple ways. We can still rely, if we're using prescription-based data, which we've used at this point, we had to define our active users, which is a very common approach using the primary care data. And then we looked at the prescription pathways. And obviously, according to the clinical guidelines, we, for example, know in Australia that prescription, in our case, which was for statin medications or lipid-lowering medications, happens every 6 months because patients get one prescription and then 5 repeats. So we've kind of modeled that first to understand the prescription trajectories. And from those, then we've chosen different time points and we've tested that in sensitivity analysis. And both of these papers in diabetes patients and in primary CVD prevention have been published, and we're happy to share them, and they're also on the slides.
There's another question which talks about conjoint modeling estimate the causal effect of time-varying adherence on other outcomes, or do I need marginal structural models or inverse probability of treatment rating or any other method alongside it?
I think that's for Harvey.
It's a really good question.
If you can go to that slide, the second last one, I think that.
Yeah.
Okay. I should probably do that.
Yeah, am I muted? No. Yeah. I don't think so. I don't think it's enough to do time-varying adherence process. I don't think that you can identify a causal effect of the time-varying adherence process or like on other outcomes.
Can you expand on the potential differences between the two?
Because usually your problem has more. Yeah, I do think you need I do think you need some inverse probability weighting on it or MSM, because you would have other confounding factors over time, such as utilization or your disease severity or your biomarker values, for example.
That's a good point, because it feels like one thing is to, like you said, model adherence. The other thing would be to look at the effect of exposure and outcome, right? Where you do need to take, especially if you're doing a per protocol analysis, kind of take into account adherence itself in the model. So, okay, all right.
Yeah, that goes back to my point that, if we look at adherence as an exposure, to completely different kind of scientific method and approach needs to be taken, versus if we look at it as an outcome. And then as an exposure, if we're looking at as predicting who's likely to be not adherent, again, it's a different kind of scientific question. But when from an outcome point of view, you would definitely need additional methods to adjust for confounding.
Well, as I wait for more questions to come up, I do have a question about the Bayesian hierarchical modeling. And I guess my question is more about to inform the priors as well as to conduct the analysis. What kind of data is needed? And I mean beyond just information about prescription or / dispensing, but other predictors and other characteristics. What kind of information would be in an ideal situation versus what do we have to work with usually?
It depends on what you're modeling, and usually the question that for us in our case, we were trying to build a hierarchy based off the surveys that we had. So we classified some of the features into adherence domains, and from there it regularizes the entire prediction model. But you could do it for postcodes healthcare systems, usually something that they share in common. Okay. In our case, it was mainly how those 3 groups varied in the amount of, when they answered those survey questions, those 3 groups varied in the amount of the variance they answered in terms of each domain. So that's what we use mainly to vary to build the hierarchical model.
Thank you.
Yeah.
We are at time right now, so thank you so much for the wonderful presentation. Thank you for everyone who's attending today's webinar. As I mentioned before, this is being recorded and will be posted along with slides on ISP's website. Thank you so much. And we'll wrap it up today.
Thank you.
Thank you.
Thank you.